Hello, my name is Troy Yocum. I'm going to be giving a webcam presentation for acute and critical illness, nursing 5461. Patient came in, chief complaint was difficulty breathing. Per HPI, Mrs. LM is a 67-year-old Caucasian female who was transferred from LTAC facility to Sierra Campus Emergency Room on 6/28/2019 for difficulty breathing. The patient was having elevated residuals, no bowel movement for the past 4 days. And this morning, while the patient was lying in bed, aspirated. The patient has an extensive history of repeated hospital admissions for aspiration pneumonia since the patient had a CVA in 2015. Over the past 3 months, she has been admitted to the hospital 4 times, with her last discharge was on May 31st, 2019. On a last admission, she had a PEG tube placed because of the reoccurring aspiration and secondary to dysphagia. Past medical history was CVA in 2015 with left hemiparesis, hydrocephalus, aphasic, dysphagia, malnutrition, hypoxia, and hypotension. Past surgical history was a cesarean section. She had a VP shunt placed in 2015 and a PEG tube placed on May 23rd, 2019. Patient's medication, she takes Midodrine, 10 milligrams TID, Crestor, 20 milligrams daily. Takes a multivitamin daily, vitamin D, 10,000 units daily. Seroquel extended release, 50 milligrams daily. Recently started on Levaquin, 500 milligrams, 3 days ago. As well, she takes Pepsid, 40 milligrams daily, Dococet sodium, 100 milligrams PRM for constipation as needed, Tylenol, 650 milligrams PRM for fever, and then she also takes potassium, 20 MEQs, extended release every other day. Allergies wise, she has none. No family history. Patient does not drink or use illicit drugs or have history of smoking. ROS was unable to attain due to dysphagia. Patient's exam, vital signs, heart rate was 113, blood pressure was 88/56, respiratory rate 41, SpO2 is 90% on a 100% non-rebreather with a temperature of 37.9 degrees Celsius. Generally, the patient looks anxious, restless, and very fearful. Pupils are equal round reactive. The oral cavity is moist, however, with a foul odor, with very poor oral hygiene, and still with residual contents in the oral cavity and along the face and neck, which were suctioned out. The neck and throat have no redness or swelling. Cardiovascular wise, the patient's heart rate is rapid and irregular, no murmur, no JVD or carotid bruit. Nail beds are pink. Capillary refill is less than 2 seconds. Peripheral pulses are +2 without any edema. Respiratory wise, upper airways have gargling and diminished throughout all lobes. Mild abdominal retractions. Skin is pale, dry, and intact. Abdomen, bowel sounds were absent, flat and non-tender, with a residual of 420 cc's. Musculoskeletal wise, there's a 3/5 strength to the upper and lower right extremities. Left side is completely flaccid. There's no joint redness or tenderness to any of the extremities. Neurologically, she's anxious, aphasic, withdrawn with a flat affect. Labs, WBC was 19.3, hemoglobin was 11.7, hematocrit was 31, platelets were 79, sodium was 117, chloride was 89, CO2 was 19, BUN was 37, creatinine was 2.4, potassium was 2.2, and glucose was 75. Assessment and plan for this lady. So first diagnosis was acute respiratory distress with hypoxia secondary to witnessed aspiration pneumonia. First plan for me was chest x-ray, stat, ABG stat, oxygen therapy per protocol had to maintain the SpO2 greater than 90%. Additionally, oral care every 4 hours for this patient. At the time, we did suction the patient, so we ordered NT suction, but we did it right there at the physical examination. Albuterol for now, nebulized, ordered Q4. Second diagnosis was aspirations, secondary to decreased gastromotility, evidenced by elevated residuals and constipation and absent bowel sounds. First thing we did was removed all the gastric contents. Ordered abdominal X-ray for placement of peg tube, and additionally just see if there was any bowel obstruction or ileus. We elevated the head of the bed to 30 degrees and we maintained an NPO. Third diagnosis was acute on chronic hypotension, unspecified, possibly due to dehydration or sepsis. Code sepsis was called. Lactic acid, we ordered a lactic acid now and a lactic acid 2 hours, and was given 2 liters NS bolus and then put on NS IV continuous at 100 cc's an hour. Fourth diagnosis was leukocytosis secondary to reoccurring aspiration pneumonia, evidenced by fever. Ordered 2 blood cultures, a UA with culture, sputum culture, CBC in the morning, and we're going to continue to monitor that WBC. Zosyn was ordered 3.375 IV Q8 hours. Additionally, vancomycin 1 gram IV now, and scheduled vancomycin additionally 1 gram Q12 hours with pharmacy to renal dose as well. Number 5 is acute renal failure. So order CMP, MAG, and FOS for the AM. Strict INOs for this patient. If a patient has no urine output for the next 6 hours, to do a bladder scan, and if the volume is greater than 400, to have a Foley placed. Number 6 was hypokalemia secondary to chronic malnutrition and dehydration, acute renal failure. Give 80 MEQs of potassium chloride IV now. Then to do a repeat BMP in 2 hours post transfusion. 7th diagnosis was hyponatremia secondary to dehydration and probably sepsis. Plans to monitor the BMP Q6 for now, Q1 hour neuro assessments as well. And then number 8 was constipation. So we ordered Dococet scheduled 100 milligrams, as well as lactulose 20 grams PRN as needed. GI prophylaxis, we started her on Protonix 40 milligrams daily. VT prophylaxis, SCDs. Additionally, she has a full code status at this time. Thank you.